this is specific to those really that are involved in reconstructive surgery, so plastics, or people that do skin cancer surgery, which could be max fax, or even general surgery in some countries, I'm sure. So, first things first, when do you want to use a local flap? One, it's going to look better than a skin graft because you're using adjacent skin, similar depth, so you don't get a contour defect. Two, the defect has a wound bed that will not accept a skin graft. So for example, if you're on the scalp, you typically take your skin down to the bone, you take it down to periosteum, but let's say this SCC invades the periosteum, you take the periosteum away. You have two options. You can burr the bone to get petechial bleeding and then try a skin graft on top of that, or you use a local flap to cover it because the local flap has its own blood supply. Or if you need a really big reconstruction, you might do a free flap, but local flap tends to work quite well if you've got local available neighboring skin. So today we're going to cover the rhomboid flap, and then maybe we'll cover the bilobe, but we might do that next time. Let's do it next time. Let's do the rhomboid flap for today. We'll do it on here and then we'll draw it on a skin pad, and so I'll show you how I do it. So this is the lesion. To mark up your lesion, let's say it's a high risk SCC, which according to the English guidelines that we use by the British Association of Dermatologists, the most recent one, we would do a 1 centimeter margin. So if I had a ruler, I would get it out and measure 1 centimeter. Fortunately, my pen has a ruler on it. And so we're just going to measure 1 centimeter. Well, the first thing is you want to mark any unstable skin. So I tend to do dots around the unstable skin because that's the limit of the abnormal. You do this with intense lights, theatre quality, and you do it with loops or a dermatoscope. I want to mark 1 centimeter from all margins. I do tend to do this with a ruler. I think it's important. And then I connect the dots. So I now need to design my local flap. You design the local flap before you put the local anesthetic in. Don't design it afterwards. The rhomboid flap is made up of 2 equilateral triangles. So you split it in the middle, or you can do it this way. What you need to work out is where you're going to take your flap from. So this line in the middle is going to be the continuation of where the flap comes from. So it's either gonna, so by drawing the line here, the flap has to either come from up here or down here. If I drew it this way, the flap will come from over here or over here. The decision as to where it comes from is literally just based on where you've got the laxity of the skin. So if I have the laxity over here, I'm going to design my flap to come from over here. So I think my laxity is up here and up here, so I'm going to take it from down here. But the key is 2 equilateral triangles. So whatever this is X. You draw 2 limbs either side to make an equilateral triangle of X length. Do not take it within the lesion, take it outside the lesion. So you don't, go as close to the skin, to the problem as possible. Don't take too much, so I'm not going to draw it out here and waste all of this because that's not involved. I'm literally as close to the skin excision as possible. And there, and then I do the same thing over here. So I'm just drawing a traditional rhomboid. Obviously this is not. I'm correcting that because that wasn't equal to that. So this has to be X, this is X, this is X, this is X, and that is X. Decide where your flap is coming from, down here or up here. It's a continuation of this line. That length, let's say my laxity is down here, this has to be able to close directly. You do that, testing that by pinching the skin. You drop your line down, the distance is X. This angle is 60, this is 60, this is 60, this is 60, this is 60. The total thing is 120. You have to draw a line either this way or this way to make the rhomboid flap. It's at the same angle as this. That is 60 degrees. Fortunately, that's parallel to this line. So I drop that down and draw my line at a length of X. It's either from here or here, whatever gets it to close. But these lines are all the same length. This angle is the same as this angle. You excise the entire rhomboid, send that off to the lab. You then incise this. The blood supply is coming from here. So you do not incise anything here, but you do lift the skin up and undermine so that you can get this to move up. So if you excise all of this and incise, you already incise this bit, you incise here and incise here, this point will come to here, this point will come to here, and this point will come to here. If you do that, this line will shift up here. So your resulting defect will be something like this. Alright, so we're going to do that in practice. We've just done a session on skin cancer principles. You can watch that back on the live channel. You can watch this back in the members only area. So this was the transposition flap that I designed. We'll do that formally, but that's in the live from before. Let's define a local flap. A local flap is where at least one edge of the flap arises from one edge of the defect. So if this is the defect, one edge of the flap has to come off from it. So it's local and it has its own blood supply. So let's say our lesion is here. It's a SCC, but this time it's a moderate risk. So we're doing a 6mm margin. That needs to be excised. As I said, where you draw your vertical line to make your two equilateral triangles is where your flap has to arise from. So I can't, let's say this is on somebody's cheek or maybe their back. This goes onto the shoulder. This is the posterior shoulder going up to the scapula kind of thing. So I don't want to take it from down there. So I want to take it from the lower back and bring it up. So I'm going to draw my equilateral triangle down here. With the back, I know I can close everything that's below it really easily. So I'd measure this. This is X. I want to draw two equilateral triangles where the length equals X. I'm conscious not to let my triangles go inside my excision margin because that will compromise my clearance rate, which I do not want to do. So again, I'd measure this with a ruler, but I don't have one of those to hand because I'm using the pen that has the ruler. That's not equal. So, two equilateral triangles. My flap's coming from down here because I know that I can close this side directly. I haven't got enough skin up there. So this is 120, this is 60, this is 60, this is 120, this is 60, this is 60, this is 60, this is 60. This length has to equal this length of my rhomboid flap, so that's X. This angle has to be the same angle of this, which is 60 degrees. So you can see that that's going to be parallel. Just incorporating that whole. My blood supply is going to come from here. I'm going to take this all out. So this is traditional rhomboid flap. So here's a modification. I showed you the traditional rhomboid flap, but we're going to do a square peg and a round hole. This is the square peg, this is the round hole. As I mentioned, this tissue in the middle, only this is my actual skin cancer. So I don't need to actually excise all of this. This is just me wasting skin. Skin has a few properties that we can make use of. Skin is elastic. So oftentimes, when I close a wound, it will draw not just from the stretch of this tissue, but also from the laxity of this. So what you can do is, you can make your rhomboid 2/3 the length of this line here. So you make it slightly smaller, and it will draw on the stretch from the sides. And you do not excise this. So it's square peg and a round hole. But you still do all these markings first. So what I would do would be, I would just mark this bit, measure this, draw it 2/3 the length. So maybe do it adjust it a little bit, and make it down to here. Shorten it a little bit, down to here. And then do my excision. So I've shown you the rhomboid. I'm now going to show you the square peg and a round hole. So I'm not taking out the rhomboid here, but I'm going to raise the rhomboid here. So, as I mentioned in the live from before, always start with the inferior aspect because the blood will run down if you start at the top. So I'm here. Traction, so I can see where I'm going. It's an SCC, so I want to go down to fascia. I don't want to do a skin graft because the patient doesn't want a skin graft because they don't like the color mismatch and the contour defect that will be left, so they wanted a more robust reconstruction. It comes with a caveat of, if you have an incomplete excision at the deep margin, the rhomboid flap has to be excised as well. Counter traction in this hand, and I sweep. So I get my plane. In this, I'm gonna just take it down to the yellow. And I really am pulling quite firmly with this hand. I'm holding the skin down with this side. In this instance, because I'm doing a local flap, I need to mark this skin cancer. So I often do this at the start, or at the end actually, with some spare suture for stitching. So I often put a clip on here, and then at the end I'll mark it. So I'd mark it, always mark it at the top. So if it's on the limb, I mark it proximal. If it's on the head, I mark it superior or cranial. Always the tops, that way if I don't comment on it in the specimen, I know I always do it the same place. So now I need to raise the flap. So remember, it's 2/3 the length of X. The thing that's stressful about local flaps is when you cut out the lesion, the defect expands. When you cut the local flap or the skin graft, it contracts. So you put all this, you do all your markings before you put local in, measure it 25 times, cut once. If it doesn't fit, put it back. You want it to be the same depth. Well, you want it to just be with fat, really, when you lift it. When you're doing local flaps in the limbs, take it with fascia. So lifting all this up. In an even plane. Now I'm going to get damp swab and hold it up. So once you get to this point, one, careful not to transect it there. Two, you need to undermine this area. So actually, where I'm going to keep raising it to get some scissors and go under and lift it off of the fascia or whatever's down there, because I need it to stretch over here. So you always have to raise it a lot deeper. By deeper I mean further back. than where your skin incision is. So you need to undermine the flap. If you see veins in it at this point, this is a skin pad in reverse, so it has suture cuts on the other side. As you can see, making full use of a skin pad. So if you have a skin pad that you have finished using, turn it over and practice your local flaps. So raise this far and wide, and then you're going to do this. So that will come there. So this needs to come here. So when you do a local flap, the first things you close are the donor site. So you need to bring this to here, this to here, and this to here. That will take the tension off of your flap. As I mentioned, this comes up to here, and this comes up to here. So you can imagine if you take out the rhomboid as well, your defect's even bigger. It's not necessary. So what you can do is you can stitch all this in like this. You can cut off this edge here, stitch this here, but stitch this bit first. And then this dog ear here, you can cut off. And that is the rhomboid flap. It's a transposition flap because it's just moving laterally. On the next session, we're going to cover the biloid flap. So tune in next week for that. But you could also just check out the video on biloid flap in the members only area on the MedSync website, medsyncltd.com/skills. Until next time.